Imagine a powerful, rhythmic mechanical pump, driving forward with full force, striking against a completely sealed, unyielding valve. The engine strains, but nothing flows. This mechanical failure mirrors the internal dynamics of obstructive sleep apnea. While often associated with loud snoring and daytime fatigue, the clinical reality of this disorder is a state of repeated, localized asphyxiation occurring dozens of times an hour. Obstructive sleep apnea, or OSA, is characterized by repeated episodes of upper airway collapse during sleep. These events cause a reduction or complete cessation of airflow, leading to drops in blood oxygen levels and severe sleep fragmentation. This is a localized mechanical and neuromuscular failure, rather than a primary defect of the brain's sleep centers. The airway physically obstructs, despite the body's continued, desperate effort to breathe. This localized failure triggers a massive physiological cascade, acting as a chronic nighttime stressor that drives long-term cardiovascular and metabolic damage throughout the entire body. Effective clinical management requires direct intervention in a recurring systemic physiological trauma. This sagittal cross-section shows the pharyngeal airway, the part of the throat behind the mouth, maintaining a clear, unobstructed path for smooth airflow during wakefulness. Keeping this passage open requires active neuromuscular tone. Muscles surrounding the tongue and soft palate must continuously brace the tissue to maintain patency, or openness, against the negative pressure created every time the lungs inhale. At the onset of sleep, natural reflex responses slow down and baseline muscle tone decreases. The walls of the pharynx become highly collapsible as the airway begins to narrow. The highest vulnerability occurs during rapid eye movement, or REM sleep. During this stage, the body enters physiological atonia, a state of natural muscle paralysis. In susceptible patients, this loss of tension allows the upper airway to collapse completely, sealing off the airflow path. Specific anatomical factors multiply this effect. Obesity, for example, increases fat deposition around the pharynx, adding tissue mass that physically compresses the airway from the outside in. Other structural risk factors include macroglossia, an unusually large tongue, as well as a naturally narrow craniofacial structure or a large neck circumference. Risk is further elevated by male gender, postmenopausal status in women, and the use of alcohol or sedatives, which further depress muscle tone and reflex responses. These internal mechanical failures produce distinct nighttime signs. Loud snoring indicates a partial obstruction, while witnessed gasping or choking points to a complete obstruction. Airway collapse is a predictable biomechanical failure occurring at the intersection of sleep physiology and individual patient anatomy. This simulated polysomnography, or PSG, a comprehensive sleep study, shows the pathological loop in action. As the upper airway collapses on the right, the airflow channel on the left flatlines, even as the thoracic efferent bands continue their rhythmic struggle to pull air into the lungs. This obstruction leads to immediate chemical changes. Blood oxygen levels drop, measured as SpO2, and carbon dioxide begins to rise, a condition known as hypercapnia. Chemoreceptors in the brain detect this rising carbon dioxide and falling oxygen, triggering an emergency microarousal. This registers as a sharp spike on the electroencephalogram, or EEG channel. This brief arousal restores neuromuscular tone, forcefully reopening the airway. Airflow spikes back to normal amplitude before the patient falls back asleep and the cycle resets. Clinicians define a scored apnea event as a 90% or greater reduction in airflow lasting for at least 10 seconds. A hypopnea is a 30% or greater reduction in airflow for at least 10 seconds, coupled with either an EEG arousal or a 3% drop in oxygen saturation. A respiratory effort-related arousal, or RERA, occurs when a sequence of increased respiratory effort leads directly to an arousal, even if the airflow reduction does not meet the strict criteria for an apnea or hypopnea. In severe cases, this cycle of collapse, desaturation, and arousal repeats hundreds of times over the course of a single night. The subjective experience of restless sleep is the result of a relentless, quantifiable cycle of repetitive suffocation and neurological rescue. Each individual apneic arousal doesn't just disrupt rest, it inflicts acute, severe physiological trauma directly on the cardiovascular system. The combination of low oxygen and high carbon dioxide triggers a massive surge in sympathetic nervous system activity. This is the body's acute fight or flight response, firing warning signals from the brainstem down to the heart and blood vessels. This produces dramatic, acute spikes in blood pressure that occur in perfect synchronization with each airway collapse and arousal. These repetitive pressure spikes lead to sustained hypertension and significantly increase the risk of atrial fibrillation, heart failure, and stroke. Metabolic health also suffers. Chronic sleep fragmentation disrupts hormonal regulation, directly driving insulin resistance, type 2 diabetes, and weight gain. The neurocognitive toll is equally severe. Without restorative deep sleep, patients suffer from impaired attention, slowed reaction times, and memory deficits, significantly increasing the risk of accidents. Untreated OSA acts as an aggressive driver of chronic systemic disease. This scale shows the Apnea-Hypopnea Index, or AHI. Clinicians use the AHI to stratify disease severity. Mild is 5 to 14 events per hour, moderate is 15 to 29, and severe is 30 or more. Since the root pathology of obstructive sleep apnea is a physical, mechanical collapse, the intervention must be a mechanical solution. Continuous positive airway pressure, or CPAP, remains the gold standard therapy. CPAP functions as a pneumatic splint. It delivers a constant column of pressurized air that physically props the upper airway open, compensating for the lack of neuromuscular tone. This splint prevents tissue collapse, stops oxygen desaturation, and eliminates arousals, effectively blunting the chronic sympathetic activation. Alternative therapies address specific presentations: BiPAP for obesity-related hypoventilation, oral appliances to reposition the jaw, or surgery for enlarged pediatric tonsils. These therapies only confer their cardiovascular and metabolic benefits through strict, consistent patient adherence. Healthy, uninterrupted breathing during sleep is a fundamental requirement for systemic health. Accurate diagnosis and evidence-based management are essential to protect cardiovascular, metabolic, and neurological integrity.